Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Hello, everyone, and welcome to Diagnosing Healthcare. I'm Tim Murphy, an attorney in the Epstein Becker Green's Healthcare and Life Sciences practice in our Washington, D.C. office. I'll be your host for today's episode. Today, we're going to discuss the impact that the COVID-19 pandemic has had on medical providers. Particularly, we're going to be focusing in on the impact that it has on providers' revenue. But before we start our discussion, we wanted to acknowledge that while our focus is going to be on how COVID-19 has led to a substantial decline in provider revenue and what the market is doing in response to that decline, we understand that the human impact on providers, particularly those providers in the largest outbreaks like New York City, is just, if not more, impactful. With that being said, I think everyone listening to this podcast is aware that medical providers have felt the impact of the COVID-19 in a fiscal sense. While many states have begun to loosen restrictions since mid-March, restrictions on elective and non-essential procedures have been in place across the country. As people have remained home under stay-at-home orders or have avoided going to medical provider offices for fear of exposure to the virus, revenues have fallen quite substantially. To try to quantify this impact, in May, the American Hospital Association released a report that estimated the 4-month period from March to June's financial impact of COVID-19 would be $202 billion in losses for America's hospitals and healthcare systems, or an average of almost $50 billion a month. Let me introduce today's guests who are going to discuss this topic with me. Here are two of my colleagues who I have the great fortune to work with quite often, Colin McCulloch, who is also in our DC office, and Paul Gilbert out of our Nashville office. Colin has, if not a unique set of credentials, then certainly a pretty rare combination. Before becoming an attorney, Colin began in healthcare finance, serving as a chief financial officer at a variety of nonprofit and for-profit hospitals. And Paul spent 10 years in a Fortune 500 health system as a senior level executive, serving as the chief legal, chief governance, and chief development officer roles during that time frame. Welcome, Colin and Paul.
Thanks, Tim. Happy to be here.
Thank you, Tim.
Great. To start off the conversation, I thought it would be helpful if, given that we hear several concerns about hospital capacity, can you guys give our listeners who might not be as well versed as you an explanation of how we can both be concerned with the capacity of hospitals and that they're operating at a loss and that they're losing revenue at the same time? Colin, what are your thoughts?
Sure. Let me sort of walk through this with y'all. Hospitals are typically geared up to treat inpatients and outpatients in the same space. They divide the inpatient space between surgical space and medical space. And within that space confined, they also have other areas for the more critically ill patients, the ICUs or the coronary critical care units, specialized units for patients that may require assistance breathing or additional monitoring of their health status. What we've seen over the last 4 months is almost complete elimination of surgical patients because of concern of cross-infection of compromised patients. And because of how the medical rooms are configured, an inability to treat a ventilator patient in some of the surgical rooms or in the regular hospital rooms, they really only need to be in the intensive care units, and there may be 10 ICU beds for 50 or 100 medical and surgical beds. So even though a hospital may have 300 beds and may have 30 or 40 COVID patients that require respirator treatment, ventilators, they just don't have the capacity for that level or that acuity. Even though they've got the excess capacity from the lack of the surgical space. Hopefully that makes sense and puts things in context.
Tim,
Go ahead, Paul, sorry.
I think the other piece of that inherent in what Colin was saying is, of course, some providers have been disproportionately impacted by the need to treat COVID patients, the imperative to treat them, while others, frankly, haven't yet seen many COVID patients. At the same time, you combine that with the guidance, the urging of HHS to providers to stop elective procedures, and to make space for COVID patients, but also to preserve PPE. And I think the financial strain on providers in that setup, of course, becomes pretty clear in hindsight.
To follow up on that, Paul, do you mean the types of providers or the geographic distribution, or is it both?
Tim, I think it's both. I think, hospitals and hospital-based physicians in major cities like New York, of course, and to a certain extent, certain other population centers around the country, we're seeing, frankly, more patients than some days they probably felt comfortable treating. I think even in those dense areas, those heavily populated areas, though, many providers who would see patients on an outpatient basis or might see patients for elective matters saw a complete drop off in their procedures and in their office visits. Even those facilities that cleared room to make space for COVID patients weren't seeing, as reported in the New York Times and other publications, even heart attacks or strokes at typical volumes. So the declines across the system, certainly across the acute care provider network, has been significant. But to your question, Tim, I think you're also seeing that among providers, individuals, and physician groups.
Thanks. And Colin, perhaps you can, I know this is the case, but you have a way with words that I don't. Can you describe just sort of how those outpatient procedures are part of what drives a lot of the revenue for the entire system?
Sure. There's basically 3 revenue streams for a hospital, or 4 revenue streams. We need to include the emergency room. Most patients are admitted through the emergency room. They're either treated there and released, or they are admitted to a medical floor or a surgical floor based on whether it's a disease or an injury, an illness that requires surgery. They may be directly admitted by a physician or a surgeon for surgery, a hip replacement, for example, or a gallbladder surgery. And more importantly, hospitals get a significant amount of the revenue, probably half the hospitals in this country, from outpatient services. And those are the lab tests, the x-rays, the MRIs, the physical therapy, all the therapies that are normally done on a regular basis. As a result of this pandemic, people are afraid to go to the emergency room. And that was what Paul was referring to with the changes in heart attacks and stroke patients. They're literally afraid to go to the emergency room for fear of catching COVID-19. So if it's not significant, it's just a precursor event, they're ignoring it or trying to wait to go to their physician.
Tim, just to tack onto that, and I don't want to anticipate questions or get ahead of you, but when you think about acute providers, hospitals, and healthcare systems who are these days employing many, many physicians, what Colin just described is occurring at the same time, or certainly did occur at the same time as those hospitals and health systems were still incurring the expense of physician payments and other salaries. So the problems and issues really sort of compounded on each other.
And so, Paul and Colin, how are you seeing providers start to respond to these challenges, whether it's the number of physicians employed or other opportunities that they might be seeing in the market because of this?
Well, they've already rapidly responded. Most hospitals around the country, at least the ones I've talked to, and most physician practices that I work with, back in February and March, started to furlough staff. They basically looked at their staffing needs, and the staff that were not as necessary for operations for treating COVID patients were furloughed. They were either put on reduced hours, or they were laid off, and the hospital continues to provide healthcare benefits. But there were steps taken to try to reduce costs because they knew that the revenues were going away. Those people were typically in administrative functions like accounting, the business office, or in the areas that the volume just completely dropped off. Again, the MRI techs, the nuclear medicine techs, the physical therapists. In the physician offices, they did similar cuts. If they were not able to convert their practice to telemedicine, which many tried to do and had varying degrees of success, they also had to right-size their offices. The problem with the physician side is even if they're in an in-demand specialty like infection control, infectious disease, they were limited in the number of patients they could have in their waiting room. So there's less throughput. So overall, there's just been a huge crash on the industry, not just hospitals, but the whole industry of huge sections that can no longer perform as they had been. Hospices and home care were not allowed in hospitals over the last few months. So their volume is dropped. And as a result, they've let people go, either temporarily or permanently.
Tim, I think Colin covered it really well. I'll just add on a couple of things that we've seen. First, the number of physicians compensated pursuant to RVU arrangements these days, is very significant. One of the first steps that we saw as we entered the crisis was an effort to rework those agreements to, in some cases, secure minimum level payments to physicians to allow them to continue, or to remove some of the sort of significant up and down swings that you might see as a result of very unusual circumstances combined with the evolution of physician employment agreements as currently in effect. And so a lot of work was required there. Staffing changes, as Colin mentioned. I think the level of outreach that certainly I have worked with providers around recently is reaching levels, frankly, I've just never seen before in terms of proactive steps being taken. And now I'm thinking primarily about physicians, but also hospitals, to reach out to patients and to help encourage those patients to come back in for the deferred matter, the routine care, the perhaps the testing driven by birthdays and those sorts of things. So a tremendous amount of outreach on top of an effort, a very significant focused effort on restructuring the cost associated with running a hospital and health system or a private medical practice.
Thank you. That illustrates a point, Paul, that I was thinking about here, and that's where are the silver linings, though they're not very bright at the moment. As you were describing, there's physician practices that are switching their models over to more of an active patient engagement, is how I'll describe it. Obviously, there are subsets of physician groups that are actually focused on patient population management, and they take risk for those patients, and they might be performing a little bit better than their counterparts that are in a more traditional physician practice. Are there other types of providers that you guys have seen that are performing a little bit better relative to the times?
Yeah, I actually have seen I would not say there are any silver linings in this. I know of no providers that are making more money or are better off financially than they were last year. I do know some providers that are not as bad off as others. So it's a case of they secured a spot in the lifeboat, but the whole thing is still going down. The examples of providers that are doing better are those that have invested heavily in telemedicine, telehealth. They were already providing telehealth services. They already had physician engagement. CMS waived some of the requirements to allow better access, improved access, lowered some of the hurdles to engage telehealth with new patients, but they also reduced some of the revenue associated with that. So those providers are basically kept whole. The other one, surprisingly, is the small rural hospitals and critical access hospitals. Not all of them, but many of them have received significant funds under the CARES Act and the subsequent legislation under the Public Health and Social Services Emergency Fund that sort of have kept them or made them somewhat whole. They were not doing a whole lot of surgeries in the elective matters, healthcare, prior to the crisis. So their volume hasn't changed as significantly, and the CARES money has been enough to take care of them, along with cost-cutting efforts, that they're not in as bad of a position as, say, a more urban hospital in a hot spot. They're not seeing a lot of COVID patients that are costly to treat. They're sort of continuing on. But again, they're not making a lot of money either. Paul, do you have any other ideas?
Those are all good ones. I would maybe just offer a couple of additional observations, one suggested by you, and I think one suggested by Tim in the question. I'm hopeful. So, Tim, I'll try to be hopeful here and try to find a bright spot. I think the bright spot may be that the walls in terms of seeking care via telehealth from the patient side, I think have come down significantly. I think going forward, that could mean that telehealth becomes a much more universal competency for medical groups, for individual physicians, for, of course, large telehealth, telemental providers. I think the ability to seek care in that way makes a lot of sense, because one of the things, coming from a hospital system that frankly always worried me is when we had too many otherwise healthy patients coming into the hospital. Hospitals are great places to be when you need to be there, but aren't necessarily the best sites of care if you have, frankly, some questions, or you need some fairly simple guidance or medical exams. So I think that's a bright spot. Maybe going forward, care is provided more efficiently. And I think the reimbursement around care provided in that manner or other what I'll just call non-traditional ways is going to improve. You mentioned value-based care. I think, the future is very bright there. And I think a lot of people have been forced, if you will, into that system through this pandemic. I think even telehealth while Colin's absolutely right, waivers and guidance and, a lot of creative thought has gone into telehealth just in the last few months. I'm working with a very sophisticated academic medical center right now, though, struggling to understand how to bill for telehealth services that they largely developed during the pandemic, which, as we know, is ongoing. But for providers to really take advantage of, frankly, the difficulties faced in the current situation, to develop those new capabilities and then to understand how to get paid for them, and to run them effectively going forward, I think, potentially is a bright spot in a very difficult environment.
And of course, all of those potential bright spots, be they value-based care or telemedicine, all have their own cost drivers associated with them in a time when revenue is scarce and everyone's trying to hold on to hopefully get through this. So it's hard to make those investments unless you are someone like a academic medical center right now. Which sort of, yep, go ahead, Paul.
I'm sorry. I think that's a great point, Tim. The divide between the haves and have-nots in the provider world have always been significant, and Colin can speak to this in a lot more detail than I can. But as you look out at the systems and at the providers who were able to make investments during this period, generally speaking, it wasn't the rural healthcare clinics, it wasn't the rural hospitals, it was the more established providers, either in health systems and networks, or the ones that were frankly already doing pretty well financially because of market location or their position in the markets.
Yeah, Tim, you started this whole conversation off referencing the American Hospital Association's study from last month. As part of that study, they also looked at the idea that there was a significant amount of stress on our hospital systems. That's who the AHA represents, that was looking pretty ugly before the pandemic in the next 5 years of planning. This has accelerated that for many of those hospitals. And since hospitals are starting to be the biggest employer of physicians, which is another change from where we were 20 years ago, it's going to dramatically change our healthcare system. You're going to see new systems forming, consolidation, new ways of thinking about doing things because you have to. It's a requirement. Financially, there's just no way to support what we've already been doing.
So you almost stole my thunder there, Colin, where this was the next question I was going to ask you is how are we going to reshape? What do we think the impact is going to have on providers, on the healthcare system? Are we looking at new joint ventures between the haves and the have-nots? Do we think we're going to see acquisitions, divestitures?
Absolutely. And this is held up, but some cases by antitrust matters, the FTC. Because you may have a town, picking on Evansville, Indiana, for example. There's two major systems in that town. There's St. Mary's and there's Deaconess. Evansville's got a population of about 150, 200,000. It can support one solid system, but it really can't support the 3 or 4 hospitals that are in those two systems. It's not big enough. But the FTC would have a hard time letting those two hospital systems merge. So you are going to see some of that consolidation. You're also going to look at new ways or new forms of doing business. So you're going to see new ventures, new ways of partnering up between the for-profits and the nonprofits, consolidation within the mid-markets, and the smaller markets are going to be hurting. We know of several large for-profits that are struggling in some of their small market locations because they just cannot get the critical mass to make money. I'm not going to name any of them, but there's more horror stories out there, and there will be more in the future.
Yeah, Tim, to pick up again on where Colin left that comment, the economic difficulty providing care in small towns was significant before the pandemic, and I'm afraid has become almost catastrophic in the pandemic. And so, while I think there are tremendous opportunities to improve the current system, I am concerned about the access to care and the access to care among various populations, including, probably easy to say, in non-urban or in rural communities. I'm very concerned about the access to care there. I think there is an opportunity here to be thoughtful about the healthcare system and to think about what truly will work going forward and frankly, maybe what should work going forward. Telehealth, expanded ways to deliver. We've talked about that during this conversation already. Ideally, hopefully, those new methods of providing care will fill in some of the gaps that I mentioned I'm concerned about. And then I think in terms of building out the system generally in a more thoughtful way is something that we've been forced to recognize as a need during the course of this pandemic. The stress that we saw in various parts of the system, we know is there now. I think some people knew those points of stress existed already, but certainly they've become crystal clear, and they're going to need to be addressed going forward. I think there's tremendous opportunity there for people who are able to try new modalities, who are able to think about new ways of doing business going forward. And honestly, I think from all of this, the health delivery system will be improved, will be stronger going forward. And I think the payment models will help drive some of that. And I think as a result, they too will be stronger and make more sense going forward. I think some of the improvements that we've felt are coming, I think probably will now come. So it's a time to be hopeful.
I'd like to suggest that you go back to the history of healthcare in this country, and it's sort of a patchwork quilt. Most of our hospitals, at least in the Southeast, are a result of the Hill-Burton grants from the 50s. So every small county in Georgia or North Florida, Alabama, Louisiana, seemed to have their own hospital, which was a point of pride for the county, even though the community wasn't large enough to support the hospital. You had the hospital try to staff it with physicians of appropriate experience and skill. And the market moved. People don't necessarily, younger people, the younger physicians coming out of school didn't want to live in these small towns. So they're really threatened with critical shortages of medical specialization that could run the hospitals, again, which is telehealth. So you have an infrastructure that's mismatched to the need, and you don't have the drivers, the physicians where you need them. And all of a sudden we're in a crisis like coronavirus, the pandemic, and we're not prepared. We don't have the resources where we need those resources. And I think that's what's really causing us to step back and think about what we're doing. We've got some hospitals that are doing well, and we've got some hospitals that are really, really struggling, and we've got to find a different model than the fee-for-service. You fill a hospital because you've invested $40 million or $100 million in the infrastructure. It just doesn't make sense anymore.
Do you think that we're going to see more payers? This is just at least one thing that I've thought about and have seen in the market before the pandemic, payers who are starting to directly provide care through different models. I know that there's certainly a lot in California that have already done this, and in the Northeast, they're starting to move into urgent care, directly providing services. Is that going to be the future, or is that just one of many?
So I'm sorry, Colin, go ahead.
We've been there before. We've been there at least twice in my career with that conversation with payers sort of partnering up with providers. This happened in the 90s. It didn't quite take off, primarily because of physician pushback and to a lesser extent some hospital pushback. It makes a lot of sense, but I'm not quite sure that we have the critical mass to get it over the finish line and actually make something happen at this point. It's a great idea. Unfortunately, there are a lot of constituencies that are against it still, and there's got to be some type of impetus to put us over that tipping point.
Yeah, sorry, I got excited to jump in there, Tim, because it's actually something that I have been watching. I'm very curious to see what happens because, as Colin just suggested, maybe it makes a lot of sense, but there have been ups and downs. We've had progress, and then we've seen people backing away for lots of reasons. The additional interesting dynamic that we have now, I would suggest, is potentially we have a number of stressed providers. And I'm speaking mainly about smaller physician groups, independent physicians, and even some large independent physician groups. Have they now sort of gone through the trauma of COVID-19, or will they go through the trauma of COVID-19 in a way that leaves them more open to those sorts of alignments? If you look at the power of value-based care and payment, and you think about that going forward and the potential power of the payers combined with the providers, there are certainly many days I wake up and I think that makes a lot of sense. If you then throw in the variable of premium dollars right now, where are they and how are they being spent? Is there tremendous capital right now being held by the payers? If there is, and my sense is that they're well capitalized right now. If that's true, then what will their appetite be to be more aggressive? And frankly, would it be helpful for them to align more closely with providers at a time when many providers, are in uncertain economic situations?
Paul, I understand what you're saying, and I don't necessarily disagree, but what has changed today compared to 20 years ago? So we've had payers owning hospitals.
Yeah, it's a great point. And so what feels different to me this time, at least potentially, because you're right, there's a lot of history here that suggests it's not a great idea. What feels different to me this time is that physicians might actually be open to it, more open than they were 20 years ago. And I don't think that's solely because of COVID-19 and some of the economic stress that we've seen as a result. I think, there have been several now generations of physicians who have come out of medical school, I think believing that they would not work for themselves, not start their own business, but might join a large medical group, or might join a group that is employed by a hospital or a health system. So I think, in a way, maybe physicians graduating today, and maybe those that have graduated for the last 10 years, have felt a little more inclined to work together in groups rather than to start their own businesses, as I said. And if the physicians can help drive this change, something that I would suggest has been missing in the past, I think that might be a difference that matters this time.
I agree with you, Paul, about the physicians. When I started this career on the finance side, physicians didn't work for other people. They were self-employed, or they worked for other physicians. The idea of them working for a hospital or a payer was, in the 90s, alien. I don't know that that's necessarily true today.
So if I could paraphrase for you through the call, Colin, there's no silver lining here, and there may not be a silver bullet either in adjusting going forward.
I think there's lessons learned, and that could be the silver lining. But it's difficult to find true winners in this. It has been beyond what anyone could have planned for. Again, I used to be a hospital CFO, and many of my clients actually are CFOs rather than general counsels, and I'm just constantly reminded why I enjoy being an attorney right now rather than a finance person, because it's financially, it's not a pretty place to be.
With that, I'm being told by our excellent producer that we're coming up to the end of the time we had set out for the episode. I wanted to make sure I gave Paul and Colin an opportunity if there were any other thoughts you guys wanted to share with the listeners today.
Yeah, it's Paul. I think that it's a time to watch, and certainly the stress put into the system has been significant, and nobody could have predicted it. I think there will be lessons learned, as Colin said, and I think there are smart people out there thinking about what the system should look like going forward. And I believe that we will hear some of those ideas in the near term. And I think one or two of those ideas will be very, very good ones. So it's going to be interesting to watch.
I echo Paul's sentiments. I mean, I'm talking to providers, and there are some really creative people out there. They're cutting deals with suppliers directly in China for personal protective equipment, going outside their normal supply chain. They're developing, as Paul's client was, new telemedicine apps. There's definitely going to be some innovation from this that should be a lot of fun to watch in the next 5 to 10 year planning horizon.
That certainly is something to look forward to. But with that, I want to thank you both for taking the time to speak today. Unfortunately, we don't get to see each other as much in the office as we used to now that we're also living under the pandemic. So it was good to get to have this conversation. Hopefully the listeners also will be able to enjoy it and get some knowledge from it and glean some ideas. So I wanted to take a moment to recap some of the things we heard today. Despite the fact that providers, particularly hospitals, may be seeing a really high volume in some cases of COVID patients, that hasn't translated to revenue, and the costs associated with that have continued to escalate. The methods that providers have to try to, I think we called it a lifeboat in the conversation, but to try to get them through the pandemic where their traditional revenues have dropped off, are also very costly to implement and take some lead time. And so it's very difficult, particularly for smaller providers and smaller groups, to implement those solutions or lifeboats. And finally, this pandemic has exposed some trends that were already existing in the healthcare system. And as a result, some of the traditional modalities of delivering care are likely to have to change. And it's in that change that perhaps the new opportunities for improvements in care and improvements in site of care and there things that we don't yet know of will likely come out of, and that will be the future spurned by this dark period. So on behalf of EBG, I want to thank you all for tuning in. I'm Tim Murphy, and this has been Diagnosing Healthcare. We look forward to having you join us again soon, and have a great day. Bye.
Thank you for listening to Diagnosing Healthcare. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.